as we go through our day-to-day lives, there are many things that can affect our heart health. Outside of known risk factors, there can be many silent things happening in your body that can affect your overall heart health. Today on Beyond the Stethoscope, we are joined by Dr. Robert Singer, a cardiologist at Nazareth Hospital, who will share some warning signs of heart problems, even if you are not experiencing known risk factors. Dr. Singer, thank you so much for joining me today.
Thanks for having me.
Yes, I'm excited to learn more about this really important topic. It affects so many of us, whether we know it or not, right?
Absolutely.
Sure. So before we get started, I would just love to hear a little bit about your career. Where did you go to school? And maybe even what inspired you to become a cardiologist specifically?
Well, since I'm in my 60s, it's a long story. So I went to undergraduate. I grew up on Long Island and then went to undergraduate school at the University of North Carolina in Chapel Hill, and then graduated from medical school at the State University of New York Downstate Medical Center in Brooklyn. I went on to residency at Albert Einstein in the Bronx, and then went on to fellowship at Hahnemann University Hospital. I practiced for over 30 years in South Jersey, more recently in Central Jersey. I was in a private practice, and recently I joined Nazareth Trinity.
Oh, congratulations. I know they're very thankful to have you. So what specifically made you want to get into cardiology?
Cardiology is fascinating. Not only do we do a lot of imaging and patient care, but the pathophysiology of cardiology is just wonderful. It's interesting. It involves so many things. It's a pump, but within the pump there are vessels and diseases of the vessels, and it's just a fascinating field within one organ.
Yeah, just one organ and just all that muscle. It's amazing. So on this episode, we wanted to focus on some risk factors. You know, it's so important that we be aware of them. Would you mind just sharing for me and for our audience, just, you know, what are risk factors that put someone at risk of heart disease, of heart attack?
So risk factors are changing, but classic risk factors include things like past heart attack, high blood pressure, high cholesterol, and certainly a family history of cardiovascular diseases. Within those, there are different subtypes of risk factors. And what we're learning right now is that we don't know everything about cardiovascular disease. You could have somebody with absolutely no risk factors who has a heart attack. And so we're starting to delve in a little bit tighter than just your basic lipid panel that people get with LDL, bad cholesterol, HDL, good cholesterol, and triglycerides. So we're looking a little bit deeper in to figure out how we could risk stratify a normal person and to know whether or not, or try to predict whether or not they're going to have a cardiovascular event in the future.
That's so important because you don't want to wait until the cardiovascular event happens.
And if I may also add, I did mention it, diabetes and obesity are large risk factors for cardiovascular disease.
Which I know we have another episode about those diabetes and obesity, so really important for all of our ears to perk up there. What would you say, what would prompt you to tell a patient that they should have, you called it a lipid panel, I think?
Yes.
Have that lipid panel done?
Well, I think everyone should have a lipid panel fairly frequently to identify if there are risk factors we could work on. We look at HDL, which is good cholesterol, and that should be high, and that's only brought up with exercise. And there are different levels for women and men. LDL is the bad cholesterol, and that should be less than 100, but in certain states it needs to be less than 70 or even less than 55. It all depends.
Wow, so it all depends. So you noted family history of heart attacks. So I was sharing with you before the episode, I lost my mother suddenly at, I consider it to be the very young age of 68. And I know, I've heard about this, and I don't think my family had really talked about it, that signs of a heart attack in men and women can be very different. And I think that's one thing that I would love to educate myself more on, of how it might look different for a woman. So could you share that with us?
Classic risk factors include chest discomfort or chest pressure, and sometimes radiation to the arms, to shoulders, neck, jaw, perhaps increasing shortness of breath. Perhaps decreasing exercise tolerance. Those are classic, and they occur both in men and women. But it's been found that women have somewhat atypical symptoms. It may be just fatigue that they're noticing. They can't go as far as they used to go. Maybe they would have right shoulder discomfort, where classically it would be left shoulder discomfort. So women are a bit differently. You have to take each patient and individualize them and listen to what they're saying. If there's something wrong, I'm not the same as I used to be, we need to look into things.
Right, probe into that. Great, that's very helpful. Thank you. So what would some risk factors be for people that maybe aren't as obvious as maybe some of the things we were talking about earlier that we could talk about?
Sometimes people with inflammatory issues, rheumatoid arthritis, lupus, which are very common issues, psoriasis, these are diseases that increase inflammation in the body and can cause rupture of plaques within the coronary arteries. Just like it's said that stress can cause a heart attack, that increases inflammation in the body. And again, you can get plaque rupture and buildup of plaque within arteries, not only in the heart, but also in the legs.
Wow.
We also have to consider, which I should have mentioned before, is tobacco use. That is what I call adding gasoline to the fire. And obviously tobacco abuse is a large risk factor. But people need to look at inflammatory diseases, family history, and there are newer tests out there that I think are used more in Europe than they are here, something called a coronary calcium score. Now, insurance doesn't cover it, but it's not all too expensive, maybe up to $200, $250. And this is a low radiation CAT scan of the chest, which could pick up coronary calcification. If you have calcification in your coronary arteries, that's plaque or atherosclerosis or coronary artery disease. And so there are certain people that have no risk factors, but yet we find that they have plaques in their coronary arteries. And those people should be treated with agents such as statins, aspirin, and work on their other risk factors to minimize the chance that these plaques will rupture or cause blockages in the future.
Wow, I'm going to take note of that. It sounds like, I mean, when you think about the cost of $200 and your heart health, it seems like maybe that's a worthwhile investment.
Now, there are new biomarkers out there, something called the lipoprotein(a), which is shown to be elevated. When it is elevated, it could increase your risk for cardiovascular disease and blockages of the aortic valve. Now, right now, there are no medications for that, so it's a once-in-a-lifetime test.
Oh, wow.
But there are medicines in the pipeline that will reduce your lipoprotein(a). Another biomarker is something called apoprotein B, or ApoB, which is commonly used in Europe, which is a better marker for overall atherosclerotic development.
Gotcha. So when we were talking about some of those conditions that can lead to heart events, I know that AFib is something that people talk about. Could you just explain for me and for our viewers a little bit more about what AFib is and how that can affect your heart health?
Atrial fibrillation is very common across the world. It's an irregular heart rhythm where the upper chambers of the heart don't contract. They quiver or fibrillate. And because the upper chambers do not contract, blood clots can form in those upper chambers, usually in what's called the left atrial appendage. And that can cause a stroke. It's one of the most common causes of stroke. And it's very common in people who are obese, diabetes, high blood pressure. It's a sign that your heart is under stress.
Gotcha. Thank you. That's so helpful because it's a phrase that I was familiar with and maybe some of our viewers are, but it's helpful to know a little bit more about that and, you know, what it can cause.
The treatment for it is usually blood thinners.
Oh, okay.
Something called, their DOACs, different brand names include Xarelto or Eliquis, that could lower the risk of stroke if you have it. And there are ways that the doctors can get rid of the atrial fibrillation either using medication or doing procedures called ablation.
Oh, ablation. I've heard of that. Thank you. And can you just for me, for my own personal interest, what is an ablation? How does that work?
An ablation is where, just like a catheterization, where the physician, usually an electrophysiologist, will go through the wrist or through the groin and send little tubes up to the heart and study where the arrhythmias are and do some electrocautery within the heart and get rid of the atrial fibrillation.
It's incredible what you can do. And that's neat. Thank you.
Absolutely.
Wow.
And there have been great advances in that field.
So I know you were talking about good cholesterol, bad cholesterol. Say if you had a patient who had never worked out a day in their life and they were looking to get their good cholesterol up, would you recommend them to ease into an exercise program? Because I know that's something that we had, it's in my notes here that it could be a risk factor to just suddenly start a program without
Absolutely.
prior training.
I think you have to start slow and gradual. And what I usually tell the patients is that I'd like you to start walking, work yourself up to 30 minutes, 5 days a week. And then after that, increase the speed that you're walking. And if you can get into, if your bones will take it orthopedically, you can take it, a jogging program, a running program.
Yeah, getting that heart rate up, right? Feels good
Absolutely.
too.
Absolutely. And also mix up the exercise, not just walking, but do a little stationary bike or biking, elliptical. Mix up the exercises so you're not hurting the hips and the knees.
Yeah, and I know weight training too, especially for some of your older patients, can be so good for kind of supporting that whole process.
Absolutely.
Right?
Increasing the strength of the core muscles. Basically, it helps prevent falls, and it also improves lipid panels.
Good to know. Thank you. So we were talking about some of those warning signs, if you are starting to have a heart attack. If you had a patient who was experiencing chest pain, is there ever any instance that experiencing chest pain should be ignored?
The answer is no. There are many instances of chest pain that are not cardiac in nature, but it's hard for a normal person to know, is this my heart, or is it just muscular, or is it, did I strain something? And usually what we look for is that if the pain gets worse, if you take a deep breath in, it's not usually the heart. If you move your arm or your shoulder or turn your head and it makes it worse, and it's what we call reproducible, it's usually not the heart.
Got it. Okay. Good to know.
Certainly if you get short of breath with it, nauseated, sweaty, 911 and go to the
911.
hospital.
Yes. Easy numbers to remember.
Yes.
It could save your life or a loved one's life. What advice do you give to your patients to help keep, at the top of their heart health game?
30 minutes of exercise 5 days a week and sweat. I want you to sweat for 30 minutes 5 days a week. I'd like you to eat and eat well, eat normal portions, which means when you go out to eat, perhaps take half of it. Don't take the whole thing. Try to keep your body mass down and the amount of fat down. Lots of green vegetables, fish, mix up your diet, a nice balanced diet. And really, it's everything that your parents told you about good, clean living. That's what you should be doing.
Right? Like it's not rocket science.
It's
Sometimes
not
it's
at all.
hard for some of us to adhere to, but I think that's wonderful advice.
You need to keep active and you need to eat well.
Keep active, eat well. Is there anything else you'd like to add before I wrap us up today?
I think that cardiovascular health in this country is being more widely viewed as an important thing to consider and think about as you go around about your daily life. We all need to keep active, we need to eat well, and we need to keep up with our physicians as far as knowing our risk factors. We need to try to avoid diabetes in the future, definitely stay away from tobacco abuse, and follow up with your doctor.
I think that's great advice. Thank you so much.
Great, thank you.
Thank you. Thank you, Dr. Singer, for all of this great information today. We hope that it helps people in our community be vigilant of their heart health. Thank you for joining us on this episode of Beyond the Stethoscope, and make sure to hit the subscribe button to get the latest episodes of Beyond the Stethoscope every other Thursday.